browsing. I have been browsing like Etsy. Like I don't need a stress test.
Sure.
Blew off his.
And then looky here, there's Dr. Tippett.
I'm a farmer, no pun. Yeah, some of the I thought you were gonna do myself. The ones who never get the dog. Yeah, I have learned. Luckily, we didn't have any. I didn't even know why to take. But the pouch. I had a weekend.
That was in the defect. That was a giant hole.
I think we're gonna be doing a little bit more for leaving issues. We'll do some.
Yep.
Really involved. Can we like I'm just remembering if I can get out yeah, like robotics that we just use like in the order to come here. Yeah.
What you can do pretty fast.
Yeah.
No, but like people and like
There's like
and that was a sign.
That's right.
He had, I think from like that morning, he had
not in the script.
I actually, we're staying closer now. We're actually friends. Not pretending.
Dr. Cherry's online, so we can't start with that.
Pretty well.
Yeah, I'm gonna do that actually.
Probably.
Never even really thought about it. Yeah, I think I was on.
Oh,
It irritated me so bad. I know. I mean,
That's how we do it. No, I didn't. I got an hour. The other data. It's just maybe use it in stuff.
the first one back to
I don't know if I really No, I mean, like, it's not because, like, I'm already there. Oh, yes, definitely. It is gorgeous. Definitely. The hall is like really neat. I love this stuff. I went for my scrubs today. Go get really yeah, I totally agree.
Either a sign or like make it system like no, it's zero like that.
Oh, really?
Yeah, gas.
I'm sorry, what? Like, yeah, but it's great.
Yeah, I'll like find out.
Yeah.
99% of it is
Then like for general
I did that.
Is this on? You guys hear me? Well, welcome to the 2024 Cherry Lecture. Dr. Cherry is here. For those of you who don't remember Dr. Cherry, he was born in Richmond. He went to Duke and he got out of there as fast as he could and came here for medical school. And excuse me, he went to I'm going to med school. Yeah, he went to med school.
I did go to med school.
Yeah. And then and then did his general surgery residency here at UVA, and then trained under Jack Wiley at UCSF. He had an illustrious career at the Mayo Clinic and came to the University of Virginia and has also finished out at Norfolk as a master open vascular surgeon. The Cherry Lecturer this year is Misty Humphries. This is someone that I've known for a while. I've known since she was a third-year resident in Sacramento when I was in Northern California. She went to Utah for her fellowship, and then she came back ultimately to UC Davis as faculty. She's now the division chief of vascular surgery at the University of California, Davis. She's been my resident. She's been my partner. She's been a confidant, and she is one of the nation's leaders in limb preservation and limb preservation development. And so we're really excited to have Dr. Humphries here as this year's Cherry Lecturer.
What an introduction. So, I'll see if I can live up to the hype. I'm a vascular surgeon. I'm talking about limb preservation. There's going to be feet. So if you do not do well with feet, I'm giving you, this is the heads up now. There's going to be some feet. I don't know exactly. I do have the part over here. So I'll try to say coming up next is going to be a foot for those of you eating. But these are my disclosures. Of course, I work very closely with industry. My research is supported by the NHLBI. And my research is very different than the research that we think about for academic surgeons. I'm interested in outcomes for patients who are underserved and systems of care. So today, as I present my work, I am not going to bombard you with slide after slide of the data. I like to tell a story. And I think as you tell a story, you get to highlight some of the work that you've done. Now, I came here from California, so there's going to be a little bit of kumbaya here and there in the talk. And I realize that we're not all primary care providers here. So if you ever feel like you're in my flight of ideas, hold on and we'll get to another place. These are just the objectives as mentioned. So I live in California, but I am originally from Texas. And sorry, that did not go as well. Somehow that slide didn't come up. There's supposed to be a little state of Texas in there that showed up on my computer, and a little star. I'm from East Texas. And I grew up in East Texas where patients don't get the best care. And I was really inspired by my grandmother who had heart failure and would travel 2 hours to Dallas every couple of weeks in order to get care. And that is where I became kind of impassioned about patients who do not have resources and have to drive long, long ways to get their care. And as I am giving this lecture, First, I had Dr. Klaus and I spoke about what I would talk about, and then I read Dr. Cherry's bio, and I freaked out, and I was like, what am I going to talk about? Can I talk about sheep? How do I talk about sheep? And I read up on the Grand Slam, as was in his bio, and it was impressive because it is the hunting of 4 specific sheep, and it takes time. The desert bighorn sheep is considered the most difficult to obtain, a lot of times because you have to get a permit, it's very challenging terrain. The doll sheep is usually the first sheep that most get, and that's what Dr. Cherry mentioned last night, and we got to talk quite a bit about this. Hunting big game is somewhat elusive, frustrating, and it takes time. It takes patience as well. And I would argue that that is what amputation prevention and limb preservation is too. I've built my career on trying to measure or trying to get to these 4 pillars of amputation prevention and limb preservation. And you think it'd be easy. You're going to set up a wound care clinic, do a multidisciplinary team. It's not hard to measure your outcomes and do some outreach. And I will spend the rest of my career chasing this because I haven't quite gotten it to the level that I want. So I'll talk to you a little bit about where I'm at, where I'm going, and how we need to change as physicians, and especially as surgeons. We need to be leading the way in so many different areas outside of doing the procedure. I heard some very beautiful cases. I had the luxury of sitting in on your M&M this morning. I love to learn from other people. I love to learn that some of the same systems issues that I raise my hand about and ask questions and fight about at my own institution happen here. And the word frustration came up, I would say at least 3 times this morning. And so I think in the era of current medicine, there's a lot of frustration from surgeons sometimes. So if we think about peripheral artery disease, this is a global health problem. And where you see the red is our well-developed countries, which clearly have higher levels of peripheral artery disease. But in Africa, where there's yellow and orange, those numbers are exponentially increasing. And a lot of it is not necessarily due to arterial disease, but a lot of it is due to diabetes. I do a global health program teaching how to create dialysis access in Tanzania. And when I went there, I was shocked at how many advertisements there were for salt. On every billboard, there's a salt advertisement. And on the opposite side, Coca-Cola, Pepsi, all of them are promoting sugar-based soft drinks. And the reason for that is it's a status symbol to not have to drink water. And so it's very fascinating to see that these countries are now shifting to where peripheral artery disease, unresolved hypertension, and diabetes are really taking over. Feet coming, here comes a foot. So critical limb ischemia is what we used to call peripheral artery disease, end-stage peripheral artery disease. We don't call it that anymore. We now call it chronic limb-threatening ischemia. And the reason for that is because it's relatively urgent. Critical limb ischemia invoked this idea that patient had to be admitted, they had to be transferred to the academic center. There was so much going on. But you have to treat these patients. It is essential for limb preservation. They need some type of revascularization. If you do not, 25% risk of above ankle amputation at 1 year, high mortality. These patients are the sickest of the sick in the hospital. And vascular surgeons run into that fire saying, oh, here, let me operate on you. Let me take care of you. But peripheral artery disease severely affects patients' health-related quality of life. In some qualitative studies that we did years ago, patients likened it to never being able to leave their house, never being able to walk where they wanted to go. And really, it was overwhelming to kind of hear some of their thoughts. When you think about chronic limb-threatening ischemia, most of what we saw whenever I was younger looked a little bit more like this. You have some ratty arterial disease. You have a wound on the toes. No, it doesn't work. So, and you have this kind of tip of the toe disease. That's not how it is anymore. It's become a lot more complex with patients coming in with wounds that look like this. And not only do they have peripheral artery disease, they have a combination of diabetes and venous disease and all the fun things wrapped into one. And so I've created this talk so that I'm assuming there's some med students. So from med students all the way to faculty, you're going to get a little something out of it. More and more, we deal with these diabetic wounds and diabetic and ischemic wounds. And really parsing these out, these were things that podiatry took care of whenever I first started. But that is not necessarily the case. These are on weight-bearing surfaces. You know, the surface is typically deformed, but the pattern of arterial disease is different. And this is what it looks like whenever I'm doing angiography on somebody who has a diabetic ulcer or diabetic ischemic ulcer. The arteries look normal. If you look at the second picture towards the right, it looks like that's the entire SFA just going straight down. What it's hard to recognize is there's this little black line on the outside of the artery, and that's actually the arterial wall. There's such thickening of the intima, the media, calcification. And while it looks like below the knee, there are 3 vessels, when you get down distally, there's really 1 vessel, maybe giving off something to the dorsalis pedal. And this is where we are trying now desperately to try and take care of these patients. And we're seeing multi-level disease in patients now. So you're spending time treating the SFA, the popliteal, the tibial vessels, and also that you can go from something that looks like this to something that looks like this, and you can get some kind of limb preservation. Because amputations in America are rising. People will tell you, and I'm going to go through the data for this, but there are 2 million patients that live with amputations. And the vast majority of them are due to peripheral artery disease and diabetes. The other half are due to trauma and also to congenital issues as well as malignancy. What we talked about a little bit earlier about patients who have an amputation or peripheral artery disease, a lot of these patients will die within 5 years. And the diabetic patients that undergo amputation, they have a recurrent rate of having a second amputation within 2 to 3 years. So this is very similar to Dr. Bauer mentioned earlier the luxury of getting to know the family that he took care of over the years. You get to know your patients with peripheral artery disease. It is in some ways the primary care of surgery because you will see them and you will take care of them for 5-10 years sometimes. But limb loss is just as devastating with a 5-year mortality. Major amputation confers a 5-year mortality that's very close to lung cancer. Chronic limb-threatening ischemia, which is that end stage before they even have amputation, also very high mortality. And you can see here with minor amputations, diabetic foot ulcers, Charcot, all of those can significantly impact mortality. We don't talk about peripheral artery disease the way we talk about malignancies, though. We don't talk about you have active disease versus being in remission. We don't counsel the patients that this is a lifelong thing a lot of times. And I think whenever you're dealing with these chronic diseases in this way, you have to change your terminology. Otherwise, patients will tell you, my favorite line, do you have high blood pressure? No, I take medicine for it. Well, baby, that's still having high blood pressure, allow me to tell you. Do I have to take the cholesterol medicine anymore? My cholesterol is normal. Yes, you have to take it forever. And really sitting with patients. I think more and more it is so hard to find the time to sit down and talk to patients when you have 15 minutes for a follow-up clinic visit and the patient has 400 questions and none of them are really relevant to what you are there to talk about, but you have to go through those because you have to build that relationship over time. So when we think about amputations throughout the United States, these are maps that were done several years ago. In fact, they were the foundation of my research when I first started. And Phil Goodney, who's out of Dartmouth, created these with the Dartmouth Atlas. And you can't give a chronic limb-threatening ischemia talk without them. So the blue is amputations per year, and the red is interventions and procedures done to prevent an amputation. And I can I've highlighted the area down here in the south where we have sort of these high amputation rates. The darker the blue, the more amputations. And you can see that they follow along a very specific area in the south. I can sort of get behind how you have a high amputation rate when you have a low number of procedures that you do. But if you look at this map and you look in certain areas, specifically down in South Texas, where my family lives now, it's very dark blue, high amputation rates, but they have some darker colors in terms of the number of procedures they do. So how do you do all these procedures to prevent amputations, and yet you still have a bunch? And that really got to the crux of where my research came in. I live in California now, and same thing, if you look over at California, there are some areas where there is a dark blue and a light yellow, meaning those patients do not get the level of care that they need to prevent amputation. But then there's some dark blue and some dark red, which means there's a lot of procedures going on and we're still not saving limbs. So what are we doing wrong? Why we're not intentionally doing it, but there's clearly something that's going on. And when we started to research this, we started to look at it, very early on, what we could say is that there are racial discrepancies. And this is something that we know, that Black patients were losing their limbs sort of triple the rate of others. In the work that I've done recently, we're going to talk about vascular deserts, which is a phrase that I've sort of coined and I think is important because we see that Hmong patients, Hispanic patients, and many other sort of marginalized groups have these higher amputation rates. But that's not to say that there's not a higher amputation rate in some of the areas where there's also just absolute poverty. Most people will tell you that amputation rates are decreasing. This also comes from Phil Goodney. And if you see that line with the dots on there, that's the number of lower extremity amputation rates. And kumbaya if everything's not doing great and it's coming down and we're doing a great job. And that's just an absolute lie. So this really bothered me whenever I started doing my research because I didn't feel like the amputation risk was decreasing. I felt like every other day I was doing an amputation for a patient. And when you start doing research, one of the greatest things you can do is emulate some other work that's been out there. It kind of gets you on a roll, gets you started. And so I decided to emulate some particular work of Phil Goodney's looking at amputation risk. And because I live in California, I had access to something called the OSHMA data, Office of Statewide Health Planning and Development, which has Medicare patients, which you get from, CMS data, but you also got all the other patients, young patients, patients who didn't have insurance, patients who had commercial insurance. The only patients it really excludes are VA patients, government controlled patients. And again, highlight these areas because you can see that dark blue, high amputation rates compared to that lighter color. This thing worked? No, that didn't work at all. And so lighter color here, especially down in what's called Kern County. And so clearly those are big areas where there's no care. But then again, big dark area colors with dark area amputations. And so this is where I've spent the last kind of 15 years of my faculty career doing research. And when we looked at this, we actually found that amputation rates are increasing over time. And the difference in this is taking your mentor's work and doing it with your own flair. So when Phil Goodney looked at all of this, the denominator in his study is patients that have diabetes, patients that had peripheral artery disease. Well, not everybody that has diabetes is going to have an amputation. And given the way we've defined diabetes over time with CPT codes, you have patients that have had diabetes for 5 minutes, and then you have patients who have had diabetes for 15 years. It's very different. And so when I started doing this work, we created these specific cohorts of diabetes, PAD, and then this combined disease. And we also took this and did it with patients that had a wound. So you were already at risk. We created a cohort of the highest risk patients. And in the highest risk patients, amputation rates are not decreasing. Amputation rates are increasing. And this is where I think that we have to change our mindset. Because when you propagate that everything's getting better, everything looks good, this idea of sort of this Pollyanna, everybody's happy and everything's fine.
Right.
I got you. I'm here for you. Then you lose track of what's actually going on and you cannot address it. And I think that's really important. So when we think about the management of chronic limb-threatening ischemia, which is where we are now, there are all these different algorithms on the left, and I'm going to talk about this a little bit later. But as a vascular surgeon, I have never in my life been on the easy way. And that is because the easy way will not get you to your goal. If you are going to be a surgeon and you're going to survive in this field, how you survive being a surgeon is that you normalize hard and you learn to adapt to hard. There is a beautiful YouTube that you can watch that talks about this from a basketball coach, and I can't remember, I'm in a southern place and I can't remember a sports reference off the top of my head, so you can hate me for that, but it talks about you don't get any better. You do a little bit, but really what you get used to is you get used to the ups, you get used to the downs, you get used to the stab in the heart, you get used to all of it. It does not mean that you stop caring, but then you still rush back in to do all the hard things because you understand that the only way to get you to the end is actually to do those hard things. So I encourage young people as they're going through this field, whenever you are sitting in the OR and think, this is so hard, there is no Prince Charming or princess that's going to come and save you as an attending. You might get a partner to come and help you, but you're there. And so normalize that beauty that you have at that moment. Do not read this. That's not the purpose of this, but the purpose of this is to show you this kind of process mapping for patients with chronic limb-threatening ischemia. If I sort of go back, you can see there's 10 different things in the management of that. That's actually not true. There are somewhere around 25 steps that it takes a patient to get their care. Seems easy. Step 1, you go to the doctor. There are 15 decision points that patients have to make. You think you have decision fatigue trying to pick out where you want to go to dinner because your significant other won't figure it out for you. There are patients that cannot even figure out, do they have an endo approach? Do they have an open approach? Do they have a primary amputation? And we do not have the time to sit as physicians and go through that. And so when you look at this, all of those blue are steps that it takes for a patient to go through the process of getting care for chronic limb-threatening ischemia, whether they go through the inpatient side or the outpatient side. And when we mapped out the barriers to care for these patients, there are 105 barriers to care. Not everybody has all of the same ones. And again, the purpose is not to read the individual ones. The categories of these barriers range. And it can be patient activation. So you can blame the patient, which we're taught never to do. It can be patient resources or health, but there are also patient or provider issues. We have the opportunity to teach patients and teach providers about what we are doing. The health system resources, and God forbid the insurance debacle that has become more and more. You have to ask for a prior authorization to treat somebody with limb ischemia. You do an angiogram on somebody who's about to lose their leg and they come back with a bill because it wasn't authorized in a prior authorization. How devastating is that? And in vascular surgery, one of the hard parts is we are still debating some of this open versus endo stuff, and we have not moved beyond. The most recent trial that we did in vascular surgery, big NIH-funded trial, was really talking about which is the best therapy, open versus endo. And the truth is the best therapy is the therapy that the patient can get. It is the specific therapy that the patient qualifies for. And when you look at the parameters of the trial, they screened hundreds of patients to end up, or almost thousands of patients, to end up with 300 patients in a trial. That is how hard it is to make a decision, and not everybody fits in those categories. So I want to promote, whenever we're talking about patients with limb ischemia, this new idea of plan. If you are ever bored, and I should have brought this global guidelines because it might have helped me fall asleep last night. It's 160 pages of just pure, dense, kind of what you need to do. And nobody has read the whole thing except Mike Conti, who's written it and can probably point to me on every page. That's on page 67. But if you go to about page 45 of the guidelines, there is this concept of plan. And many other fields have done this, but vascular surgery has not done this as well, in my opinion. They look at patient risk, limb severity, and then we look at anatomic class, and we come up with actually what each patient, this precision medicine. Precision medicine in vascular surgery has been challenging. The nice thing is that when we start with this, overall, I anticipate that we will get to an AI point. But physicians are notoriously bad at predicting how patients will do. A lot of times in vascular, we saw this case of an 84-year-old patient today. There's not always the luxury of saying, we're not going to offer you something. Imagine when that patient came in, you walked up to them and you said, hey, I'm Dr. Humphries. You're really sick. Is today the day you want to die? Or would you like me to go and take care of you and try to do something to fix this for you? Patients are overwhelmed. We don't say it that way, and I say it in that crass way, but that's what you're asking them. Do you want us to take care of you? Do you want things done? Do you understand what it's going to be? They have no concept of what it's going to take, but they trust their physicians. And we are notoriously bad at saying, okay, this patient is the right patient for this procedure. We love the concept of frailty in medicine these days, and we predict it with all of these different kind of areas. I'm very old, and I get Botox, that's why I look so young. But in California, everybody does it. Just come on out. I got a guy, I got a girl, we'll take care of it. But there's this trial called the CARP trial, and I still love this trial. The CARP trial is one of the things that I really kind of hold on to in my practice, because the CARP trial said, you can do all this workup for vascular patients. You can see if they have any type of cardiovascular risks, but you're still going to do the case. You're still going to offer them limb preservation. You're still going to take them to the OR, and you're going to do the aneurysm resection or for that patient, because that patient said, I want this done. And they've accepted that. So we try to predict frailty, still don't do it very well, but we can predict mortality when we're thinking about patients who have chronic limb-threatening ischemia. And there's this calculator that I use. I would say probably, 20% of people are really doing this whole plan thing throughout the country. But you can go into this calculator and you can put in a bunch of numbers. And these are the factors. This is based on research by a friend of mine, Jess Simons, who's out of University of Massachusetts. And they looked through, and this actually will predict, do patients have a 2-year survival? What is their 30-day survival? When you put all of these different factors in, age, ambulation, kidney disease, whether they're on certain medications, you can come up with a certain risk to say, okay, this patient's going to live less than 2 years. Let's do an endovascular approach. This doesn't need to last very long. Or this patient is going to live much longer than we thought. Let's offer them an open surgery. But what we get is we get physicians who are not willing to take this on, because we still continue to believe that I can look at up there and say, I think I've got this. And this study really did show that there are different rates of mortality. So when you put this in the calculator, you have a low risk, medium and high risk. And those medium and high risk patients really do fall out in terms of their survival at both 2 years and 5 years. And this is what helps us make the decisions in the plan. So the other thing that we don't necessarily do as well in vascular surgery is the use of the Wi-Fi tool. I use this in our wound care clinic. We use it in our vascular clinic. And we use it because it allows us, and we try to promote it in primary care clinics, because in the nature of a limb preservation center, there are patients who need to go to podiatry, and there are patients that need to get a revascularization. And those patients are in two different camps. And so early on, you can predict who needs to get a revascularization versus who needs to go and see a podiatrist and can have their care managed there, or who needs a complex foot reconstruction and needs to see if you have orthopedic providers that do that, et cetera. So this is the tool itself. It's made up of 3 categories: wound, ischemia, and foot infection. And it goes through these areas. You can choose 0 to 3. Again, it's kind of that simple, 0, 1, 4, or 3, something like that. And then it breaks it down into stage 1 through 4. And when you map out different patients, everybody in green goes straight to podiatry. That's the person that they need to take care of. Yellow, orange, and red, they come to see the vascular surgeon. Even though the L means, I'm going to make it simple, very low, low, medium, and high. That's what the letters stand for. So you can tell, even if they're a low level of needing an amputation, which is the top one, or even a low level of needing a revascularization, which is the bottom color chart, you really can't tell these days. When patients get ABIs or they get things out in the community where there isn't a dedicated vascular lab, those can be wrong. So we ask to see everybody who has any evidence of ischemia. And if patients get sent to the vascular clinic and they have a normal ABI but no toe pressure, we take them in first because we realize that not everybody can do toe pressures. Only about 50% of patients that come to see us in the wound clinic and have a vascular problem have ever had a pulse exam or have ever had any kind of assessment of their perfusion. That's a study that I did a couple of years ago looking at patients that came, they had known vascular disease. We retrospectively looked at them. And in the primary care setting, only 50% of them got either a pulse exam or some kind of assessment of their perfusion. And so that's really devastating. You think it's easy to stand up and say, are we not teaching this in clinics? Are we not teaching this in medical school? But again, when a primary care provider is seeing a patient for 15 minutes and we're demanding so many things of them. So in our clinics, we use the Wi-Fi score. Our nurse practitioners are fairly well versed in it. And they know right away if they're seeing a patient and we've been following the patient and their ischemia level drops or their wound is in a different area. They will contact me to let me know because I run our wound care center. I'm the vascular provider that's in our wound care center. And this is what our clinical documentation sheet. I'm happy to share it. It's just a piece of paper. We have a bunch of laminated ones so that whenever our nurse practitioners are working, they can just use the laminated one. They don't have to fill it out for each patient. We used to, in the beginning, we would fill it out for each patient and scan it into the EMR. We now have a dot phrase that makes this. And so for every patient that I see in the wound care clinic with a foot wound, we are documenting where their Wi-Fi stage is because our goal is to send them to the right provider. The last thing that I really want to talk about in terms of how we do this is glass. And so this glass classification is something that in the guidelines, people are moving towards promoting that for certain types of glass classifications, patients should get an open procedure versus an inward procedure. Before there was glass, there was task. There are other, there's the Rutherford classification, there's a Bollinger classification, there are multiple different classifications. Again, in the clinic, it is really hard to use these. And a lot of times these are reserved for research. And I'll show you, this is what the glass classification is. So again, you go through 1 through 4. And unlike the Wi-Fi where I can look at the toe and be like, okay, that's easily a 1 because it's minimal. I have to go back and look at the angiograms and I have to look at all of this. Is it 1/3? Is it 2/3? Nobody's using this. It's too complicated. And even though you can bring it out into stage 1 through 3 of disease by mapping these out, this becomes in a place where it's really complicated for practitioners to put into practice. And so it's not used. And that's something that is devastating because it does predict kind of where we are. In this particular thing, endo versus open, the argument that we've been making for years and years on this trial, or on this particular paper, are both the Mike Conti, who wrote the global guidelines, and Andrew Bradbury, who just did the basal trial over in the UK. And they're both on here, and they're both big proponents of using this system, because you can tell that if you're trying to do an endo approach, which is in blue, the patency or your freedom from major adverse limb events. Ooh, don't we love acronyms in medicine? So that's MAIL is major adverse limb events. It's losing your leg, having to have another procedure on that leg sometimes. But when you're doing endo in these patients, there's a much lower level of freedom from that. So we know the results of this. We didn't have to spend necessarily millions of dollars to kind of design this trial. The last thing I want to talk about in terms of the grand slam of what I'm looking for and trying to promote in limb preservation is targeted outreach. So we did some studies looking at where amputations were higher. And again, I use California data because it's where I live. It was the easiest for me to get. The blue triangles are major cities. The darker the color, the higher the amputation rate per patients with wounds. And the Central Valley, which you can see all along those little blue dots there, that is where some of the higher amputation rates as an aggregate are. But there are pockets of areas between the Central Valley and the coast on that side there, where that is where there are a lot of indigent populations. We have a lot of Indian reservations as well. So this red, dark red area that's about halfway down on the screen here, that is an area where there is a large Indian reservation. And in many of the places in the Central Valley, there are no board certified vascular surgeons, which means these patients are not getting a certain level of care, or a level of care that I think that they deserve. So when we started looking at this, we mapped out all of the amputations so we could choose places that we were going to try to target for outreach to help decrease amputation rates. I do not know if you have ever tried to implement or done any implementation science of programs that will change people's practice patterns, but it is just about as easy as that sentence came out of my mouth. It is one of the hardest things to do, to get providers, to get patients, and to get systems to actually realize that they need maybe a higher level of care, that they need something different. Years ago, I took care of a patient who, very similar to what we had today, had a ruptured aneurysm, and he came from the Stockton. It's only about an hour away from where I live. And I said, I need to see you from now on because we put a graft in and, I want to make sure it doesn't leak. And he said, Doctor, you may be better than what care I can get down there, but I'm not coming back here again. An hour is too far for me to go. I don't have that ability. So you have to think outside of the box when you want to do targeted outreach. And how do you get from, not just from your facility, but to the patients? And so I set up a clinic in this area here. Sacramento, where I live, is where the red star is. It's in a big blue circle way up at the top. This clinic over here takes me 6 hours to get to. So I'm clearly not going every Tuesday to see patients in this clinic. But this is a place where they have no vascular surgery providers, they have no podiatrists, and they have a high rate of amputation rates. So how do you do it? How do you get your care, the care that you provide out there? The town is called Lone Pine. If you're into mountains and climbing mountains, it is where Mount Whitney is, highest mountain in the continental United States. I realize Alaska, but I live in California, so I'm from Texas. So wherever I'm at, it's bigger, better. We live in California. Mount Whitney's the most important thing. But this is the hospital. This is the entire healthcare system there. That's every single person that works there. So it's small. And to provide the level of care that they needed, what we had to do was we had to build this sort of quality care our program. We did telemedicine. We taught the providers how to do some of the ABI exams. We taught them how to do foot exams in a way that they didn't get through simple wound care programs. And then we did telemedicine clinics with them 3 days a week for every patient that they saw for 3 years. And by the end of 3 years, they had built themselves into a system where they turned this and they were able to go on without our help anymore. They still call, we still do consulting roles for them, but it became this advanced wound care collaboration. But with this, you had to develop multidisciplinary teams because within this area, There was no vascular surgeon. There was no podiatrist. And we were 6 hours away, so they couldn't just come there. We went, this is the team, this is the wound care team there that you see at the top. Frankie is the one on the left-hand side. Frankie's the primary wound nurse. And then Renee is in the middle. And so over time, they would go to where the podiatrists are. They asked the podiatrist, would you see these patients in telemedicine with us? And they would. So we would see wounds, another foot, nobody's eating anymore. So we would see wounds like this, where you have a Charcot foot. That person doesn't really need a vascular surgeon, but they need a podiatrist who's going to take care of them. And so an hour away, there's a podiatrist. We would set up their care with them. If they needed a vascular provider, they had to go 4 hours to one. But we had somebody that would work with them through telemedicine, we would do CT angiograms to assess all of their blood flow. And that's really quickly and very nice, easy way to figure out where the disease is, so that when they come to this facility, and we've started one of these in another location, and they now come to my facility, but when they came, we already knew what their vein looked like. We knew where the disease was. We could do an angiogram on Monday. We would have them in the OR for surgery on Tuesday, just because we needed to see the tibial vessels to map those out a little bit. And then we could get them home by Friday. And that's a level that nobody else could provide. And it's still a level that in Sonora, which is where my personal clinic is, that they don't have. So the last thing, again, I want to talk about is, and I want to focus on outreach, because I think outreach is not what we think about in surgery. You measure outcomes, you do a multivariable analysis, you put it out there, and then you keep mining the data over and over and over to find the same results 15 years later, which is what we're doing sort of in BQI. But we mapped out vascular deserts, and this is something that's fairly easy to do. We looked at places in blue is where people can get any type of vascular care. In green is where you can get vascular care from a board-certified vascular surgeon. And in red is where you can get vascular care from a center of excellence, or an area that participates in outcomes for patients with limb ischemia. And you can see that the red is really, really small, and it's very spread out within very populated areas. The top is San Francisco and the Bay Area. The bottom is LA, and there are 2 places in the Central Valley, Sacramento, where I live at the top, and then Bakersfield is down at the bottom. And we realized that these vascular deserts held so many patients who needed care and couldn't get it. And we mapped out the demographics, we mapped out the poverty level, and much to my surprise, it wasn't what I thought it was going to be. You know, again, when you do research, you get an idea in your head of what it's going to be. And I thought we were going to find all of these amazing patients who needed our care. And really, we found that there are some deserts where the patients have plenty of resources, and there are some places where they don't. So I partnered with one of the people that's at Leanne O'Banion, who's down in Fresno. That's at that lower part where that red dot was. And we started to do specific outreach so that we could target places or vascular deserts where they did have patients who were in the highest levels of poverty, where they did have patients who had the lack of access to primary care providers. And we do these things. It's called the Champions Program. It's something that she's developed. But we do these programs where patients come to a city fair or the Raisin Festival, or whatever festival there might be, the Frog Festival, and they go through and we map out their age. We do cholesterol screening. This is all from an industry grant from Abbott. They bought us a machine that can do hemoglobin A1C testing and all of this on site in the middle of a festival. And we mapped these out, and what we found is that, again, not all deserts are created equally. So this small area here, which is in between those 2 big red dots, but there's a lot of green, meaning there are board-certified vascular surgeons all throughout that area. They actually do not get great vascular care. And the reason for that is because they're very different. And I'll show you some of they represent really the lowest of the socioeconomic groups. So in most of our deserts, the population is about 75% white. In the non-deserts, which are our urban areas, it's 55. But in these pilot areas where we were targeting, the population of Hispanics is 67%, and 83% live 200% below the poverty level. They cannot go to get the care that they need. They do not have a primary care provider. And so this is something that we're now focused on, again, setting up these kind of remote clinics and remote processes there with primary care providers and educating primary care providers. We have a system that teaches ABI. We have a system that goes out and teaches them how to do a pulse exam. And we try to promote this in the primary care setting because they are really on the front lines. And then again, you can see that there are, in these, where the numbers are down at the bottom, healthy person index is what HPI is, educational percentile. The lower the number, the worse the conditions are. And so only 30% of these patients have any ability to transport more than 1 hour away. So these kind of programs are popping up everywhere. We have VISTA, which is through the Society for Vascular Surgeons, the Champions. The SAVE Clinic is a clinic that is run by Lisa Ochoa. She has a van. I think she calls it the tow truck. And she has an ABI machine in it. I think she has 2 tow trucks actually. And so she has these ABI and toe pressure machines and she drives around San Antonio and they do these fairs and they do all of these. And I just think it's a great name. But it's really hard because you can sit in the, what I like to call the ivory tower that is UC Davis, and I can ask patients to come and get their care from me, and I can tell them I'm going to do a great job, but they're not going to do it. And so we have to move outside of our comfort zone, and we have to actually go into some of these areas and do things vastly different than we're used to. I can tell you that most people would not do a bypass surgery on somebody they'd only seen maybe one day. They want to have those conversations. We have those conversations remotely. So again, I want to encourage everyone here to normalize hard. The hard way is not the easiest way for sure. It is definitely not the straightforward way. It will never be, but it is the way that gets you to your goal. And when you look out and you think this is too hard, over there it's easier. You know, why is the grass greener on the other side? Because we all believe in some ways that it is greener on the other side. But the grass is greener on the other side because some guy spray painting it, and that's not the real color of the grass. The grass is just as dead over there as it is where you are. The grass is green, actually, where you water it. So when you are in a place and you see things that you want changed, you get that opportunity to water the grass. You get that opportunity to make the change. And there is, you know, the first time people try to scale Everest, they're not always successful, shocking but true. But they keep going back. And they keep going back, and that's what surgeons do. We keep doing the same thing over and over, and we come to M&M and we learn from other things, and then we go back out into the fire. So I'm going to end simply because, you know, I feel like I've just kind of been smacking you in the face for the last couple of hours, or for the last hour. So I'll get off the stage in just a second. But the landscape of chronic limb-threatening ischemia is changing. To do limb preservation, you have to do it with a plan. We need physicians that are doing research outside of what is accepted necessarily or what is thought to be the research, doing the qualitative work, doing public health work, and really leading, calling attention to the public health problems, and then doing outreach. And then follow your passion. It's not going to be sexy. I don't do aortic work. You couldn't beg me to do an aortic case, although I do them quite frequently. I would rather do a tibial bypass to the lateral plantar in the distal foot for 17 hours than do one aortic case. And so follow your passion and the grass will grow around you. And so I'll be happy to take any questions. Okay. Yes, Dr. Tracy.
Oh,
Yeah, bring it on.
it was a fantastic talk. You're a great speaker and you've really taken on an important cause. So I took a picture of the 105 barriers to care slide partly because all of those letters were too small for me to read right now. I'll read
Even
them
if you mag it up on that thing, I'll send it to you. You're not gonna read it.
glasses, but you know, over the last, you know, probably almost 15 years, you've really done a lot of work trying to figure out what those barriers are, work them through and overcome them one by one or two by two in this process. What are the biggest barriers to care you think in our health system that could be potentially changed?
I think I talked a little bit about this yesterday. Academic health systems are notoriously inefficient, and that is one of the challenges. I do not understand why, if somebody puts a referral in, it takes so long for the referral to be processed and then get to me. Whenever, if you called me and said, hey, can you see this patient tomorrow? I'd be like, yeah, go on down. You know, it's in my, I'll put them in. Yeah, I'm a little overbooked. Oh, we're overbooked a lot. Yeah, that's okay. You know, I'll figure it out. We'll be fine. The physicians want to actually do the work. They want to provide that level of care. But I think there are systems in place that just don't allow that. You know, when a referral comes into our clinic, we have a patient contact center. So they get the referral first and then they send them to our clinic. It'll take them a week to get that referral just to the clinic to our triage nurses. And then our triage nurses sometimes want to get all the studies and all of this other stuff, and that just delays it. So we have to be comfortable as physicians, and they'll come to me and they'll say, I can't get this paper, I can't get the studies on this, and this patient doesn't have ABIs. Are you willing to see them? Yes. Bring them in. I can see them without an ABI. I can do an exam. I can do a physical exam. I don't need a CT scan. I can diagnose things without having to get a CT scan necessarily. I can do a physical exam. And I think we get uncomfortable with that. Surgeons are asked to make decisions with such limited information. We will take an ACS patient to the OR not knowing diddly. So we'll take that patient, the 84-year-old guy was 84, 87 with the gastric, with the air all in the liver. We're like, let's take that guy to the OR. But yet in the clinic, we're like, well, we need to get this and we need to get that and we need to do all of this, and we delay things. And that all adds up. Patients are asked to come back again to get the ABI studies, but then they got to come back again to get another CT scan or vein mapping. And we don't make it convenient. It's not patient-centered in any way. It is centered around health systems making money, and it is centered around physicians in terms of convenience sometimes. And that's what's hard. And I can't change that. I'm gonna work on it. But I don't run the complete world yet. I only run my little world. But when I run the whole world, I'm going to change that. Yes, sir.
I just want to say how much I enjoyed that. And I can count the number of talks I've heard about clinical limb ischemia that I enjoyed easily on one hand. But I truly enjoyed yours. I'm a little worried that you don't want to do aortas and you'd rather spend 17 hours at the end. But I'm sure they have mental health facilities out there too.
And that's with spliced vein too. That's spliced and vein, you know.
But no, seriously, it was a wonderful talk and very exciting. And the work you're doing is really something special.
Well, thank you. Like I said, it's hard to go outside of what is accepted as mainstream research sometimes to really push the boundaries. But if surgeons don't do it, and it gets done by people that propagate different things. And I think that I've had the luxury of being in a place that supports research on a different area, qualitative work. The NIH was looking for systems of care work, implementation science when I was applying. And so they have been very supportive of that. And we're seeing that transition, but it's really hard sometimes for us to see surgeons in that field. And it is so uncomfortable. Again, I would rather do that distal bypass sometimes than analyze qualitative work or ask the questions and come up with that, because it's hard and it's outside of my comfort zone. But that's what we do. Yes, ma'am.
So, Dr. Humphries, great talk. I want you to elaborate on what you just commented on, because we have a lot of people in the audience who will not be going into vascular, but probably do want to start programs in clinical research, outcomes, quality work, etc. And one of the biggest questions I would always get is, how do you start when you're just starting out in your career? So what advice can you give the folks in this audience about how to do that from the very beginning?
I sort of mentioned this in the beginning, but I'll elaborate on it more. The things that I did initially was I took somebody else's work and I recreated it as my own. So Phil Goodney, who I've presented a couple of his papers, he has been generous to me. He is my mentor. And when I went to him and I said, I don't think you did this right. He's like, well, you do it right then. And he guided me through how to do it in the way that I thought was better. Or again, I'm a woman, so of course I can do it better than a man can. But he's like, this is how you do it. This is the way to go. And so we went through those steps, and he was very supportive of me. Find mentors who are generous with their time, who are willing to give you all of their knowledge in certain ways and resources. And that's the hard part. But I took his work and I emulated it in my own way. And then from there, I spun off into different places. So much. When we go to Journal Club and we talk about these papers, and we can rip a paper apart. They did this wrong. They did that wrong. They should have considered this. Well, then do it. Do it your way. Do those things and recreate it in a way that you think is actually going to answer the question. And then when you get there, you think, that's not the question I thought I was going to get the answer to, or that's not the answer I expected. Then go chase that answer down and go chase something else. And you will spend your life chasing the grand slam of sheep. And eventually you will get to a place. I am nowhere near all 4 of those things. I have 2, and I'm sort of working on 1, but you will spend your life chasing what you love. And then ultimately you will get to a place where you get to say, I did it. It just takes tenacity. There's a fine line between insanity and tenacity. When you're in the OR at that 17th hour and you think, this is insane, and then there's a pulse in the foot, there's a fine line between tenacity and sanity. So you just have to kind of walk that sometimes.
You have a picture of 5 Air Force officers. What is the connection between your program and the Air Force?
So the Air Force officers are residents. The women in the front, except for the 2 flanking, are the faculty. So Dr. Geis is a military physician. Dr. Kwong, who's in green, myself, Dr. Hediati, and Dr. Keller are our faculty in the Division of Vascular Surgery. And then the rest are our residents that are around them. We have a civilian and a military residency. And so it's the military residents come through. They interact just like the civilian residents are. You would not know the difference that one was military versus one was civilian unless you looked at their paychecks. So you know where they get paid from. But other than that, it's an integrated program. And it's wonderful because our civilian residents get the luxury of going to work on the Travis Air Force Base and getting to take care of those patients. But we also work with a VA. Dr. Hediati, who's in pink, is the chief at the VA. And so they also get the ability to go and work at the VA and serve all of our servicemen and veterans.
Well, thank you, Misty. That was an amazing time. We really appreciate it. A very, very, very difficult subject that you're making a dent in.
You and I have they might have different version of amazing, so just.
Well, thank you very much. We're really glad that you came to the University of Virginia. We have a little memento of the day for you. And we're going to take some pictures, but thank you everybody for coming and have a great day. You did a really good job. Started and I was out of